Welcome to the new section on primary amenorrhea and Turner syndrome. In this particular section, we'll be initially reviewing the basics of the female reproductive physiology one more time in a very small and understandable way, not in a very detailed way as we did already, just to make sure that you understand the future concepts better. And after that, we'll be going to the etiological principles of oligoamenorrhea in a woman, and we'll be also discussing on the algorithmic approach of primary amenorrhea, and finally we'll be closing down the chapter with Turner syndrome, which is very, very important for your exams. And a neat and detailed understanding of Turner syndrome is very helpful from genetics perspective as well. So let us start with the basics of the female reproductive physiology, which we are going to discuss in a very short way. So you start with the hypothalamus. You know this hypothalamus is going to produce this gonadotropin releasing hormone GnRH. And remember, this GnRH will always be produced in pulses. Remember, continuous production of GnRH or continuous stimulation of the GnRH receptor will result only in loss of FSH and LH released from the pituitary and not production of FSH and LH. So this GnRH pulses, especially the type of the GnRH pulse, is going to determine what is the hormone that you will be releasing from the pituitary. For example, if the GnRH pulse is fast, this faster GnRH pulses is going to produce a LH or a luteinizing hormone predominant release from the pituitary. Or if you are going to produce a slower GnRH pulse, this slow GnRH pulse is generally associated with the FSH predominant response in the pituitary. So which means the type of the GnRH pulse which should be acting on the GnRH receptor in the pituitary on the gonadotrophs is going to determine what hormone you are going to release from the pituitary on the adenohypophysis. So there are some things that can modulate this GnRH pulses. For example, there are some things that can inhibit and slow down the GnRH pulses. For example, your dopamine, which is a neurotransmitter, and your CRH and POMC. CRH and POMC, corticotropin releasing hormone, and POMC or ACTH for that matters, can slow down the GnRH pulses. And number 3, more importantly, your endorphins can reduce the GnRH pulses. Remember, the CRH and POMC itself can stimulate the production of endorphins, and at the same time, one of the cleavage product of this POMC itself is your beta endorphin. We have studied that already in the basics. And you can watch one thing very closely here. These compounds are compounds that are produced in stressful scenarios. Whenever the body undergoes stress, you're going to release cortisol, which is going to in turn increase the endorphin, and dopamine also will be released. And all these things together is going to slow down the GnRH pulse. Whenever you slow down the GnRH pulse, you will produce more of a FSH predominant response rather than an LH predominant response. If you're not producing LH and you're producing more of an FSH, means without LH, you cannot produce ovulation and the patient will end up with anovulation. It's understandable and the body's natural adaptive mechanism that whenever the woman is under stress, the body thinks, okay, the hypothalamus thinks, okay, this is not the right time to produce ovulation and fertility because the woman is already under tremendous stress. So let's stop the ovulation and keep the women infertile for some period of time till the stress is resolved. So this is a natural adaptive mechanism. Now, there is one more thing that can slow down the pulses. That is progesterone. Very, very important. That's how progesterone produces negative feedback with regards to LH to the pituitary and the hypothalamus, because progesterone is a strong compound that is going to reduce the LH and it's going to favor more of FSH production. It's not in absolute terms, but you have to understand that it's going to reduce the LH related responses. So there are some things which can even stimulate the GnRH pulses, or you can increase the GnRH pulses. The most important being estrogen. We know estradiol, especially when its levels are more than 200 picogram per ml. This is a threshold. When it is more than 200 picogram per ml and it is sustained for some period of time, this estrogen will change its phase to a positive feedback hormone rather than being a negative feedback hormone. So this is one of the important positive feedbacks that are happening in endocrinology. So it's going to produce a positive feedback, stimulating the hypothalamus to produce more faster GnRH pulses, which in turn is going to produce that LH surge, which is going to ultimately result in ovulation. And second thing, norepinephrine, noradrenaline can produce this faster GnRH pulses and produce a LH predominant response. And number 3, there is some peptide called as a kiss peptin. This kiss peptin is going to act on the hypothalamus through something called a KIS1 receptor. This KIS1 receptor, when it is stimulated by this KIS peptine, they are going to produce more of a faster pulses of GnRH, and this is one of the stimulating things for GnRH pulses. So who's going to produce the KIS peptine? So which means KIS peptine production can be increased by stimulating the leptin receptor. So now the next question, who's going to stimulate this leptin receptor? Obviously the name itself suggests it will be stimulated by leptin. And as a cascade, the next question comes, who's going to produce this leptin? This leptin is going to come from the adipocytes, right? Adipocytes. So adipocytes, whenever they are filled with fat, they are going to produce variable levels of leptin. Whenever they have more stored fat, they are going to release more leptin. Whenever they have less stored fat, they release less leptin, which means leptin is a signal of energy, adequate energy in the body, or too much energy in the body. So leptin has more of appetite mediated effects, which we are going to discuss in the obesity chapter, but at the same time it's also going to have this GnRH effects that is mediated through this KIS peptine through the KIS1 receptor. So this has a very important clinical correlate. So for that matter, suppose anyone who's going for rapid weight loss, for example, patients who are suffering from anorexia nervosa is going to have a very rapid weight loss and they go below critical weight. So these individuals generally tend to have sudden decline in the stored fat. This will result in sudden decline in the leptin production. Sudden decline in the leptin production will result in sudden decline in the stimulation of the leptin receptor, which in turn downregulates the KIS peptine production, which in turn is going to downregulate the stimulation of the KIS peptine receptor, which in turn is going to slow down the GnRH pulses and make the patient prone towards more FSH related responses, and they won't release LH at all, and the patient goes for anovulation. Clear? And this is understandable once again, because anyone who is suddenly going for undernutrition, remember, if the patient is already lean, not having sufficient body fat, and they don't have much problem because their body is adapted and the hypothalamus and the body knows that this is the nutrition that they have for a long period of time. But if you suddenly lose weight, your hypothalamus thinks that, oh, something is wrong, and this patient is suddenly going for undernutrition. And whenever the patient suddenly goes for undernutrition and malnutrition, and this is not the right time to produce ovulation, and this is not the right time to produce fertility, and let us stop the fertility for some time being and let the patient become with a good body weight once again, and let us start the fertility after that. So that is the reason why it's an adaptive response to this sudden undernutrition and sudden weight loss, and that is the reason why many of the anorexia nervosa patients will have hypothalamic amenorrhea that is truly functional, and that is because of the loss of the GnRH response producing luteinizing hormone, resulting in anovulation. So this is something very, very important to understand. And what is the final thing that I want to tell in this regards is the point that whenever you have a hypothalamic problem, you generally tend to slow down the pulses rather than completely stop the pulses, which means you will result in a normal FSH, because the slowing down of the pulses will result in FSH production but not LH production, which means you are resulting in very little LH production. So this will be the usual picture that happens in hypothalamic issues. Whenever you have hypothalamic issues, slowing down of the GnRH pulses, reduce LH, but you will be preserving the FSH responses. There are some textbooks which gives low FSH also. These are very trivial. Advanced level of understanding is normal FSH with low LH as far as hypothalamic problems are concerned. Unless until you completely destroy the hypothalamus due to some destructive lesions, you will not result in loss of this FSH. In general, they will produce normal FSH and low LH only. So you know there are multiple mediators that are going to regulate this FSH and LH. In general, let me first finish off the FSH. FSH production can be down-regulated very importantly by two compounds. One is the inhibin. Inhibin is the most important in both males as well as the females in down-regulating the FSH production from the pituitary as well as the hypothalamus. And to an extent, estradiol can inhibit the FSH production, but the most important feedback comes from the inhibin only. And there are some substances that can stimulate the production of FSH, and the most important being activin, the details of which I've already told you in the basics of female reproductive physiology. And this activin is in turn regulated by a molecule called follistatin. This follistatin is a molecule that modulates the activin action, but still you can understand simply like follistatin is going to inhibit activin, so that overall effect of follistatin is to downregulate the FSH. Clear? So what are the things that are going to stimulate the LH production? The most important stimulator of LH production in the periphery is going to be the estrogen, especially the estradiol. This estradiol levels, if it goes beyond this 200 picogram per ml, and this is the threshold that is needed for production of this LH surge, which is ultimately going to result in ovulation. And this LH can be downregulated by a very, very important hormone, that is progesterone. We know that progesterone is going to give maximal feedback to the LH only. It's not going to give feedback to the FSH predominantly, even though little feedback is there for the FSH as well, but the majority of the feedback of progesterone is based on LH, because progesterone is going to slow down the pulses and it's going to reduce the LH production. So now these hormones is going to produce a lot of changes in the ovary. Clear? So first let us understand what will happen in the follicular phase. We have already described, but let me tell you what is needed right now. In the follicular phase, we know that there will be some amount of LH and there will be some amount of FSH as well. This LH is going to stimulate this theca cells to produce this androgens. This androgens will be converted to the estrogens by the famous enzyme called aromatase enzyme, and this aromatase enzyme is present in the granulosa cells. And this granulosa cells, on the other hand, is under the control of FSH. Clear? Remember, the early primary follicle is FSH independent. It has very little affinity towards FSH, but the late primary follicles and the Graafian follicles are highly dependent on FSH. So that you have to understand. The early primary follicles are usually relatively FSH independent. Anyways, they are going to produce estrogens by this mechanism. This estrogen has multiple actions. One is priming the endometrium, which means it makes the endometrium in the uterus to go for proliferative changes. This priming of endometrium is very, very important for later progesterone action. Without this, the progesterone action will be useless. And this estrogens also is going to produce this LH surge. This LH surge is going to result in ovulation as well. So especially when it goes beyond this 200 picogram per ml, they are going to produce ovulation. After this ovulation, we know the fact that you are going to result in formation of this corpus luteum, and you have these luteal cells. Remember, both the theca cells as well as the granulosa cells become luteal cells under the influence of luteinizing hormone. That LH surge is the one that is going to cause this luteinization or luteal transformation of this theca cells and the granulosa cells. You know, after ovulation, in the luteal phase, the most important hormone that is produced by these luteal cells is the progesterone. And to an extent, they are also going to produce estrogen as well. So this progesterone is very, very important for two reasons. One, it's going to produce secretory changes in the endometrium, which means they produce something called endometrial maturation. I can also call it as endometrial maturation. Remember, estrogens prime the endometrium, whereas progesterones tend to mature the endometrium. So which means endometrial maturation and secretory changes are dependent on the progesterone. And this progesterone is also going to inhibit the LH. We know that. So remember, so these luteal cells are dependent on LH. If increasing progesterone suppresses LH, so the LH support on the luteal cells will be lost, and if there is no support by LH, it will result in formation of corpus albicans, and they no longer produce progesterone. It will result in menstrual bleed. But remember, these luteal cells can be supported by beta HCG. Suppose if the patient is conceived. We have seen that already. If the patient conceives, if the patient becomes pregnant, this beta HCG will be produced by the fetus, and obviously they will give support to the luteal cells, which produce continuous progesterone, which will sustain the pregnancy. Otherwise, the pregnancy will be lost. So once if there is no conception, we know that fact again. If there is no conception happening and no beta HCG, and with declining LH, so this declining LH will result in loss of support to the luteal cells, and this luteal cells will go for dead cells, that is called corpus albicans. So this corpus albicans will no longer be able to produce progesterone or no longer be able to produce estrogen. So this loss of estrogen once again will result in FSH, and the continuation of the next cycle and the follicular phase will start again. So this withdrawal of this estrogen and progesterone together, and especially the progesterone, is the main reason for development of this menstrual bleed, which sheds off the superficial layer and the basal layer will still remain intact. So this is the reason for the menstrual bleed, and you have to understand the fact there are two things that are important for development of this menstrual cycle, menstrual bleed, that is the initial endometrial priming with estrogen and later endometrial maturation with progesterone. Both are very, very important. If you don't have any of this, you will not get the menstrual bleed. So we'll be discussing that again because this has a lot of diagnostic importance as far as your secondary amenorrhea investigations like progesterone challenge and estrogen progesterone challenge is concerned. That time you will understand, because we are going to discuss hyperandrogenism and secondary amenorrhea in the next chapter. But try to be with me that this is the basic physiology that is happening. I have told the entire physiology in a nutshell. So after being understood about this entire physiology, let us go on and discuss the oligoamenorrhea etiologies. What are the etiologies of oligoamenorrhea? It's quite simple, right? First, we have to know the definitions of this amenorrhea and oligomenorrhea. So first, amenorrhea can be divided into either it could be a primary amenorrhea or it could be a secondary amenorrhea. So what do you mean by a primary amenorrhea? Primary amenorrhea means a girl has not experienced cycles till 15 years of age, which means till her 15th birthday, she has not experienced cycles at all. So that is one definition of primary amenorrhea. Or the girl has not experienced cycles, any spontaneous menstrual cycle, even after 3 years of telarchy, which means what I mean by telarchy is breast development. In simple terms, I can call it as breast development. Even after 3 years of breast development, the girl has not yet achieved menstruation, spontaneous menstrual cycle. So this is primary amenorrhea. And what do you mean by secondary amenorrhea? It depends on whether you have regular cycles or whether the girl is having irregular cycles, which means this particular girl, to be called as secondary amenorrhea, should have already got some spontaneous menstrual cycles. After getting spontaneous menstrual cycles, if the girl has regular cycles and if they are amenorrheic for at least more than 3 months, so we call it as secondary amenorrhea. In a girl who's having irregular cycles, this definition can be relaxed to at least 6 months of amenorrhea. So in general, whenever in exam you just get the definition of secondary amenorrhea, you can go for this 3 months as the answer, which means in exam, the examiners assume any girl to have a regular cycle by default. So, but anyway, so this 3 months and 6 months are very, very important from the secondary amenorrhea perspective. So what about oligomenorrhea? When you call it as oligomenorrhea, oligomenorrhea depends on your post-pubertal age. Suppose in the first year of post-pubertal age, so you have to see post-pubertal or a post-menarchal age. So in the first year of post-menarchal age, if the girl experiences less than 4 cycles per year, it is considered to be oligomenorrhea. In the second year of post-menarchal age, if the girl experiences less than 6 cycles per year, it is considered as oligomenorrhea. In the 2nd to 5th year of post-menarchal age, if the girl is having less than 8 cycles per year, we call it as oligomenorrhea. After 5 years, and remember, trust me, this is the definition of gynecological maturity. 5 years of post-pubertal life, 5 years of post-pubertal age is what we refer to as a gynecological maturity. So once the girl has achieved gynecological maturity, by definition, after 5 years of post-menarchal age, if the girl has less than 9 cycles per year, so this is what we define as a oligomenorrhea, which means in an adult woman, so this you can consider as a definition of oligomenorrhea. So the 5 years mark is the time where you call it as a gynecological maturity. So why you call it as 9 cycles per year, not 12 cycles per year? Many students have this doubt. It's very simple, because your menstrual cycle is not fixed. Depending on the textbooks, the normal menstrual cycle ranges from 21 to 35 days, and Williams endocrinology tells like normal cycle ranges from 21 to 42 days. It all depends on the ethnic groups as well as racial preferences. So since your normal menstrual cycle is very widely distributed, like up to 42 days. You cannot keep 12 cycles per year as the standard. So that is why this 9 cycles has been kept as a standard, and anything less than 9 cycle after achieving gynecological maturity is what we call it as oligomenorrhea. So what are the conditions or causes in general that is going to produce oligomenorrhea? We're going to see the same hypothalamic, pituitary, gonadal and uterine axis. So let us consider the causes one by one. First, we have this hypothalamus. We know that there are many conditions which can affect this hypothalamic pituitary area. So separately we are going to discuss about the pituitary also, but what are the conditions that are going to produce this amenorrhea or oligomenorrhea due to hypothalamic issues. But before evaluating any etiology for oligo or amenorrhea, always rule out pregnancy, which is a very, very important point. So UPT is a must in any case. Always rule out pregnancy, because a girl or a woman can get pregnant at any time in their reproductive age group. So always rule out pregnancy. So what are the conditions that cause oligomenorrhea due to hypothalamic pituitary pathway? So in general, we are calling about hypothalamus. So first, we are talking about mass lesions. Yes, a lot of mass lesions are there, which I will discuss in some time. Then a lot of infiltrative lesions can cause, for example, conditions like lymphocytic hypophysitis sometimes can start infiltrating the hypothalamus as well. Then tuberculosis, sarcoidosis, many infiltrating conditions are there which can produce hypothalamic dysfunction. And third one is the insult to the hypothalamus. Whenever I talk about insult to the hypothalamus and the pituitary, I mean of trauma and radiotherapy. In general, this radiotherapy is very important, which we'll discuss in some time. And at the same time, there is another entity called hypothalamic amenorrhea. What is the percentage of percentage contribution by hypothalamic causes towards oligomenorrhea in a woman? It's astonishing. Almost 35% of the causes are predominantly due to hypothalamic and pituitary pathway, or predominantly hypothalamic lesions. So, and the most common cause for this is the hypothalamic amenorrhea. And among the hypothalamic causes, the most common cause is the hypothalamic amenorrhea. It's also referred to as something called a functional hypothalamic amenorrhea, called as FHA. So this is the most common hypothalamic cause of oligomenorrhea. So what is this hypothalamic amenorrhea? I told you, a lot of conditions can result in slowing down of the GnRH pulses. One of the important things that slows down the GnRH pulses is the stress. So any stress or systemic illness that involves excessive production of cytokines can result in reduction of the GnRH pulses, resulting in poor production of LH and anovulation and amenorrhea. So two important examples as far as exams are concerned is type 1 diabetes mellitus patients who can have functional hypothalamic amenorrhea, and patients who are suffering from celiac disease. Both are important from exam perspective, whom they can have this hypothalamic amenorrhea. Apart from that, any condition that produces gross systemic illness because of excessive cytokine production, you can result in hypothalamic amenorrhea. Remember, this diabetes and celiac disease also have their own central mechanisms to produce this hypothalamic dysfunction, but in general, you can understand this as systemic disorders. And apart from that, exercise, sudden increase in the exercise resulting in rapid weight loss. As I told you, this acts by this leptin receptor and kisspeptin mechanism, already I explained in the physiology, can produce this functional hypothalamic amenorrhea, and even severe obesity, sudden increase in the weight also can confuse the hypothalamus, resulting in hypothalamic amenorrhea. And after bariatric surgeries, that again will come in rapid weight loss. Post bariatric surgeries also, some patients may experience this hypothalamic amenorrhea. Remember, there are certain hormones that are also resulting in amenorrhea due to this central mechanisms, like for example, low thyroxine and high cortisol. Remember, low thyroxine, do you remember what I've told in non-thyroidal illness or CQ thyroid syndrome, where low thyroxine is one of the signs of stress in the body or any systemic illness? Because of the effect that is similar to non-thyroidal illness, hypothalamus thinks whenever there is a low thyroid, it will think that the patient might be having stress. So that is the reason why they reduce the GnRH pulses, resulting in anovulation. And excess cortisol, cortisol is a stress hormone, And the same principle applies here. Whenever there is excess cortisol, even pathologically, for example, due to Cushing's disease, the hypothalamus will start thinking like, oh, the patient is having high cortisol, so the patient is under stress, so let us stop the GnRH pulses. So this is what is happening in hypothalamic amenorrhea. So these are the conditions, these are the various causes that can produce this hypothalamic amenorrhea. So very, very important to understand. As I told you, this hypothalamic and pituitary causes generally tend to have a normal FSH, but a low LH. So this will be the finding you will see in hypothalamic causes. Clear? So now let us move on to the pituitary. So there are a lot of pituitary causes are there. Amongst the pituitary causes, the most important being the radiotherapy. So that's what we are going to consider about, because radiotherapy can affect the pituitary as well as the hypothalamus, even though the hypothalamus is more radiosensitive compared to the pituitary. So we know that pituitary is going to produce this growth hormone. In response to this growth hormone releasing hormone, they are going to produce prolactin, and this is predominantly controlled by dopamine, and they are going to produce this TSH, and the main controlling hormone is the TRH, and they are going to produce ACTH and POMC, and the main controlling hormone for this is CRH, and finally they are going to produce this LH and FSH, and the main controlling hormone for this is the GnRH, gonadotropin releasing hormone. Remember, these are hypothalamic hormones, these are hypothalamic substances, and which I have not shared are the pituitary hormones. Clear? So remember, as I told you, it's a very important point to know that hypothalamus is more radiosensitive compared to that of the pituitary. So which means whenever the hypothalamus is affected, surely the pituitary also will be affected. That's the idea. So what are the radiation doses that can affect each and every different type of hormone? For example, you need a radiation dose of more than 12 guys to affect the growth hormone production by affecting the growth hormone releasing hormone production. So similarly, you will be needing a little bit of more than 30 guys to affect the TRH production, thereby reducing the TSH. And you will be needing approximately more than 24 guys to affect the CRH production from the hypothalamus, thereby reducing ACTH and producing central adrenal insufficiency. And you will be needing again more than 30 guys to affect the GnRH production, to reduce the GnRH production, so that you will reduce the luteinizing hormone production. Clear? But one important point that is related to this radiation and your dysfunction of the hypothalamus is the fact that more than 30 guys will reduce the LH and probably the FSH production, even though LH is more reduced compared to FSH. But remember the fact that any radiation in the range of 12 to 18 guy, which means these are low dose radiation, any radiation in the range of 12 to 18 guys may actually paradoxically stimulate the GnRH production, and they can result in precocious puberty if the affected individual is a child. Very, very important point, which means low dose radiation will have a positive effect on GnRH producing precocious puberty, and a high dose radiation will have a negative effect on GnRH producing amenorrhea. It's a very, very crucial point to know. And these are the effect of radiation on hypothalamus and the pituitary. So now once you have known about the radiation effects on hypothalamus and pituitary, let us see what are the conditions that will affect the pituitary in general. So first one is the mass lesions, which can affect the pituitary. We have discussed in detail about this. It could be a cellular mass, it could be a star issue, or it could be a supracellular mass as well. We know the examples of cellular mass. For example, you have a pituitary adenoma, which is far more common compared to other causes, or it could be a Rathke's cleft cyst, or it could be a craniopharyngoma. All of this we have discussed already in the basics of the pituitary. And stark causes usually will be infiltrative causes, or it can be lymphocytic hypophysitis, which in turn itself is a infiltrative causes. Usually lymphocytic hypophysitis can happen in pregnancy or those patients who are receiving ipilimumab. We have already discussed that, and it's going to produce ACTH deficiency and TSH deficiency, and it can produce GnRH deficiency as well. And supracellular masses are generally either a craniopharyngoma or a Rathke's cleft cyst. So all these things we have discussed already. These are the mass effects on the pituitary causing problems in the GnRH production. I mean LH and FSH production. And next one is the increased prolactin. Increased prolactin can happen due to variety of causes, lots of causes. All these things we have discussed already in the pituitary section. I'm not going to discuss once again because we don't want to kill time unnecessarily. And next, it can happen as a result of insult to the pituitary. So insult to the pituitary can be a trauma in the form of a pituitary surgery like transfemoral surgery, which can remove the bulk of the adenohypophysis and render the patient panhypopituitarism. And or it could be due to ischemia and infarction resulting, for example, a lady with a Sheehan syndrome. We have discussed that already in detail. Or it could be pituitary apoplexy, or it can be affected by radiotherapy as well. All these things we have discussed just some time back. We have discussed about radiotherapy and to discuss some of the issues about radiotherapy in the pituitary section also. So these are some of the conditions that can produce amenorrhea. These are some of the pituitary causes. And now let us move on to the ovarian causes. Remember, whenever you have a pituitary issue, what will be the FSH and LH? In hypothalamus, I told you, generally you tend to have a normal FSH with a low LH, but as far as this pituitary is concerned, you're going to produce very, very low levels of both FSH as well as LH. It's not like you'll have a normal FSH, definitely you'll have a low FSH and low LH if you are affecting the pituitary directly, predominantly at least. Now let us move on to the ovarian causes because it's a hypothalamic pituitary gonadal axis. So we are going to have some ovarian causes also. So what are the gonadal causes or ovarian causes? Remember, these pituitary causes are going to contribute to 15% of oligoamenorrhea. Like hypothalamic causes, I told you it contributes to 35%. Similarly, pituitary conditions will contribute to 15% of oligoamenorrhea, etiologies of oligoamenorrhea, and ovarian causes are the most common, contributing to 40% of the oligoamenorrhea in a woman. Which means this is going to be the most common, at least by simple numbers, because a PG aspirant needs numbers, isn't it? And the most commons. So this is going to be the most common. And ovarian causes could be anything starting from ovarian dysgenesis or a gonadal dysgenesis. This gonadal dysgenesis can be due to variety of reasons. We have discussed already. It can be due to WT1 defects. It can be due to NR5A1 defects, which I have seen in the previous chapter, which can be due to SRY defects, which can be due to DAX1 defects, or it can be due to SOX9 defects. It can be due to any defect, gonadal dysgenesis. Similarly, it can be due to steroidogenic defects, where the ovaries are unable to synthesize estrogen. Steroidogenic defects. So there are some steroidogenic defects which I told you which will manifest as delayed puberty. We have discussed in detail in the steroidogenic defect section. At the end, I put a summary where I have clearly told you conditions like star and side chain cleavage enzyme deficiencies and 17-hydroxylase deficiency, aromatase deficiency, or even a P450 oxidoreductase deficiency. All these things can manifest as delayed puberty. If you have any doubts, you can go back to the steroidogenic defects and you can see those disorders once again. Or it can be due to ovarian insult. This ovarian insult can be due to radiotherapy very commonly, or it can be due to some drugs. This is very, very important. Remember, radiotherapy to the pelvis, especially maybe after a cervical cancer, if you undergo a pelvic radiation due to some other reason, your ovaries may become dysfunctional. Remember, ovaries are more sensitive to this radiation after the puberty. Usually pre-pubertal girls are generally a little bit less sensitive to radiation compared to the post-pubertal girls. And that's a very important thing to understand. And among the drugs, many cytotoxic drugs are there for the ovaries, and the most important cytotoxic drug is going to be the cyclophosphamide. This I'm going to substantiate and tell this multiple times in rheumatology because in many conditions like SLE and rapidly progressing glomerulonephritis in your nephrology, we are going to use this drug that is cyclophosphamide, which can kill the oocytes and it can make the patient completely infertile, which means cyclophosphamide can reduce the follicular count and it can produce premature ovarian failure. So that is the reason before starting with cyclophosphamide, you have, especially if the woman has not completed her family, or if it's a young girl who is not yet thought about that fertility issues, you have to always discuss about this to the parents, and you have to discuss about that to the women in particular and tell them that cyclophosphamide can cause this fertility issues and you can reduce the fertility because of reduction in the follicular count and ovarian insufficiency. And the patient may even go for menopausal symptoms after starting with cyclophosphamide. It has to be very clearly told, and if the patient deserves to be fertile, so either do not use cyclophosphamide, option number 1, or you can go for preservation options, like you can go for oocyte preservation, or we called as oopexy, or you can take the entire ovary and you can go for cryopreservation, so that you make sure that you document these at least, because it's one of the legal issues as well. So cyclophosphamide is a very important drug, especially at a dose of more than 200 milligram per kilogram doses. It is highly gonadotoxic. It can kill the testis as well as the ovary. Very, very important cause of infertility. And then you have a PCOS. PCOS is the most common in this group, to be honest. It's one of the important ovarian causes of oligoamenorrhea and anovulation. And the details of PCOS we have discussed in great detail and great depth in the next video. So no need to worry about this PCOS right now. And you have this premature ovarian insufficiency, or otherwise referred to as a premature ovarian failure. Both are similar terminologies. And it is imperative to know about this premature ovarian failure to an extent, where this premature ovarian insufficiency can be divided into conditions which produces lower follicular count, or this can happen in patients who are having normal follicular count, which means even in the presence of normal follicles, you might have this ovarian insufficiency. So what are the conditions that produces lower follicles? Some examples of those conditions are karyotypic abnormalities like Fragile X syndrome, or radiotherapy, or exposure to drugs like cyclophosphamide, which I have discussed already, insult to the ovaries, which can reduce the follicular count and they may produce premature ovarian insufficiency, or in some patients it can be completely autoimmune nature also. So remember, autoimmune is the usual cause compared to all those other causes, and beware that whenever you have an autoimmune cause of ovarian insufficiency, you have to rule out other polyglandular syndromes also. Because whenever the patient is having autoimmune ovarian insufficiency, the patient might have other endocrine dysfunction like autoimmune thyroiditis, type 1 diabetes mellitus, pernicious anemia, vitiligo. All these things come under this autoimmune spectrum. So you have to think about other autoimmune problems as well. So patients who are having a normal follicular count means it is a resistance, which means the patient is having a gonadotropin resistance. So which means they are not responding to this FSH and LH. The etiologies of gonadotropin resistance may be either idiopathic, which is far more common, or it could be some congenital causes where there can be mutations in the FSH and LH receptors. The best example for this is your pseudo-hypoparathyroidism. That's what the examiner likes. So remember, the pseudo-hypoparathyroidism is a condition which is due to mutations in the GNAS gene, which produces this GS alpha protein. Remember, this G stimulatory pathway is very important not only for PTH, it's also important for the gonadotropins, FSH and LH. So whenever there is a mutation or a damage to this GNAS receptor, that is GS protein, so it will result in resistance not only to PTH, it might also result in resistance to gonadotropins. Not all the types are due to GS alpha mutations, especially your type 2 pseudo-hypoparathyroidism is not due to this GNAS mutations. And not all pseudo-hypoparathyroidism types will have this gonadotropin resistance. Only your types 1A and 1C. There are basically many types, 1A, 1B, 1C, 2 and 3. These are the types of pseudo-hypoparathyroidism, but this type 1A and 1C will have additional gonadotropin resistance in addition to PTH resistance. Clear? So this is what you have to know. So this is one of the important causes that you have to know. So premature ovarian insufficiency or premature ovarian failure, the definition means the patient has achieved menopause or ovarian insufficiency before 40 years of age. This is what the definition of this premature ovarian insufficiency or premature ovarian failure. So in any ovarian cause, it is imperative to find out your ovarian reserve. It is a very important test for infertility as well. So what are the tests of ovarian reserve? The most important test is follicular stimulating hormone levels, FSH. We know FSH is inversely proportional to the ovarian reserve and the number of follicles. So whenever the number of follicles reduce and the ovarian reserve reduces, the FSH is going to definitely increase. Which means whenever the FSH is 0 to 10, You can call it as normal, but remember, low FSH can be seen in pituitary causes and rarely some hypothalamic causes as well. But in general, hypothalamic cause will have a normal FSH, but pituitary causes can have a low FSH. You have to be very clear about the 0-10 is what we call it as a normal or a low FSH. You can take it in the context what you're dealing with. So anything in the range of 10 to 20 is a borderline or a dangerous FSH, where the patient is having ovarian insufficiency, but it's a borderline dysfunction. Anything in the range of 20 to 40 international units per liter will tell you that the patient is having probable ovarian insufficiency, not confirmatory, but suggestive of ovarian insufficiency and ovarian dysfunction. Anything more than 40 is confirmatory of ovarian insufficiency, which means in a patient who is more than 40 years of age, this FSH more than 40 confirms physiological ovarian insufficiency, that is menopause. Clear? If it's less than 40 years only, we call it as a premature ovarian dysfunction or premature ovarian failure or insufficiency. Clear? So, but the problem with the FSH is it is variable throughout the menstrual cycle. So, we have to do it on day 2, 3 generally for FSH, and it's variable throughout the menstrual cycle. And at the same time, a lot of confounding factors are there for FSH as well. For example, PCOS can produce a normal FSH. I mean, we are going to discuss that in the next section, in the hyperandrogenism section. So, PCOS can have a normal FSH. So, there's a lot of confounding factors which you have to keep in mind. Second is the anti-Mullerian hormone. AMH is one of the best tests right now for ovarian dysfunction. So, because AMH is something which is not going to be like fluctuating throughout the menstrual cycle, which means its values are constant throughout the menstrual cycle. So, you can test anytime during the menstrual cycle. There is no particular days for doing an anti-Mullerian hormone, and the normal values of AMH is somewhere around 1.5 to 4 nanogram per ml. This is a universal normal value. Anything less than 1.5 is suggestive of ovarian dysfunction. Anything less than 0.5 nanograms per ml is confirmatory and definitive for ovarian failure and reduced ovarian reserve. And third thing, what you can use is the antral follicular count or AFC. What you do is generally around day 3, you try to do the antral follicular count by transvaginal ultrasonography, TVS, transvaginal sonography. You do the manual counting of the follicles. So generally we count the 2 to 9 millimeter follicles. These are mid-sized follicles. These are the best to be counted. And these 2 to 9 millimeter follicles, if they are less than 4, it suggests of poor ovarian reserve. It is suggestive of a poor ovarian reserve. Anything more than 10 is suggestive of a good ovarian reserve. Anything in the range of 5 to 10 is borderline, but anything more than 10 is a sign of a good ovarian reserve. Clear? So, but remember, this test again can be falsely positive in polycystic ovarian syndrome, the details of which again you will be seeing in the next chapter. So, remember, in polycystic ovarian syndrome, there can be a lot of unmatured follicles, and these follicles might be increased in number. So, this will not really tell you the true ovarian reserve. So, AMH is right now the best test, and remember, clomiphene citrate mediated tests are also done, but these are a little bit more cumbersome, and we are not going to utilize these tests anymore. The best test right now, which is used by many endocrinologists and gynecologists, is still the anti-Mullerian hormone. Maybe you can use inhibin, but both are similar tests, but AMH is the best test right now. So, test of ovarian reserves. And remember, there are some rare conditions which also produces this ovarian failure, like galactosemia. But I don't know the significance of this in exams, but they generally don't ask this. But what will be the finding in ovarian dysfunction? You generally tend to have high amounts of FSH and LH, isn't it? Especially if the FSH is going to be high in patients who are going to have a ovarian dysfunction. Clear? But remember, one important exception is there, that is PCOS, where you can encounter normal FSH. That's a very, very, very important point. PCOS can have a normal FSH. Be very clear about that. Clear? Fine. So now we are moving on to the uterine causes, which means a lot of uterine conditions may result in oligoamenorrhea. So one of the things about these uterine causes is the fact that they generally tend to have a normal FSH and LH, which means they are not related to ovarian dysfunction or hypothalamic pituitary dysfunction, which means the hypothalamic pituitary gonadal axis is intact. The problem is in the ovaries. So in India, the most common cause is obviously TB endometritis, which causes adhesions. or it can be due to iatrogenic adhesion formation in the form of Asherman syndrome, which is due to over-enthusiastic dilation and curettage, where you remove the basal layer. When you scrape off the basal layer, this Asherman syndrome might be happening. Or it can be due to certain Mullerian conditions or uterovaginal agenesis like Mullerian agenesis, or some other malformations of the uterus. So in exam, you will be often encountering this uterovaginal agenesis, otherwise called as Mullerian agenesis, or simply you can call it as Mayer-Rokitansky-Custer-Hauser syndrome, which I have discussed already. And apart from the uterine causes, there can be some cervical causes like cervical stenosis, which can also result in amenorrhea. Apart from that, you may have conditions with outflow tract obstruction. This outflow tract obstruction can result in primary amenorrhea. Like for example, this can be due to vaginal atresia, but uterus may be perfectly alright, or it can be due to imperforate hymen. So which will be looking in the speculum as a bluish colored membrane, most of the times bluish bulging membrane at the introitus, imperforate hymen, or it can be due to a transverse vaginal septum. In all these conditions, FH and LH is supposed to be normal. So usually this outflow tract obstruction will lead to a peculiar phenomenon called hematocolpos and hematometra, which means hematometra is the accumulation of blood in the uterus and hematocolpos is the accumulation of blood in the vaginal tract. And this accumulation of blood in the uterus and the vagina might compress on the urethra, resulting in urinary retention as well. In extreme cases, we have seen even fecal retention also. So these are some of the problems that you're going to encounter with outflow tract. These are the uterine causes, and trust me, uterine causes generally tend to have a normal FS and LH, and they contribute to less than 10% of the cases. So they are not very significant in practice, but still you have to think about these causes. So you have discussed about a whole lot of causes, starting from the hypothalamus to the pituitary to the ovaries to the uterus and vagina. Remember, hypothalamic conditions generally tend to have a normal FSH with a low LH. Very rarely they can have a low FS in LH, but generally tend to have a normal FSH and low LH. And pituitary causes tend to have a low FSH and a low LH, significantly reduced in fact. And ovarian causes generally tend to have a high FSH and a LH, with one important exception, that is PCOS, where the hormonal levels may be variable. In general, they tend to have a normal FSH with a high LH. And uterine causes and vaginal causes or outflow tract obstruction generally tend to have a normal FSH and normal LH. These are the things that you have to understand as far as the etiology of your oligomenorrhea is concerned. So with this, we'll move on to the algorithmic approach of primary amenorrhea. We know what is the definition of primary amenorrhea. I will just say it for one more time. If the girl has not achieved any menstrual cycle till 15 years of age, or if the girl has not achieved menstrual cycle after 3 years of breast development or thelarchy, so this is what we define as a primary amenorrhea. So whenever you encounter a primary amenorrhea, what you are going to think about? So you have to see whether the patient is having adequate estrogen or not, which means if they are not producing estrogen, obviously are going to result in primary amenorrhea. If the patient may be producing estrogen, but they may still be encountering amenorrhea, and what are the causes for the same? So first, you need not directly test the estrogen. Everything is clinical. So you can see the secondary sexual characters, which are important effects of estrogen, right? So look at the secondary sexual characters. If the secondary sexual characters are there, the most important thing I'm going to look at is the breast development, which is completely dependent on estrogen. Clear? So if the secondary sexual characters are there, or if the secondary sexual characters are not there, which means there is no breast development, which means in this condition I'm talking about low estrogenic states, which means estrogen is not there to produce this breast development. So whenever you have a good breast development, the next step is to do an ultrasound and a good clinical examination. So to look out for the uterus. So you have to see whether the uterus is present or uterus is absent. Uterus is present or uterus is absent. Uterus is present usually goes towards outflow tract obstruction or probably some other condition, which we'll be discussing in the next chapter. So when uterus is present, next step is to do an MRI. And ultrasound itself will tell you, and clinical examination will tell you the diagnosis, but MRI is the gold standard in this condition. So if MRI is showing outflow tract obstruction, MRI showing outflow tract obstruction, now the diagnosis is clinched outflow tract obstruction may be due to a transverse vaginal septum, or it can be due to a imperforate hymen, or it can be due to vaginal atresia. All these things can be easily diagnosed by an MRI. So that's why the next step is an MRI. So if MRI is showing a normal anatomy, normal uterovaginal anatomy, in this condition, it could be anything. So you have to evaluate similar to that of secondary amenorrhea. How will you evaluate a secondary amenorrhea? Remember, evaluation of secondary amenorrhea I have discussed in great detail in the next chapter. So evaluate for secondary amenorrhea. As how will you evaluate for a secondary amenorrhea? You are going to evaluate in the same way. For example, you will be doing multiple soup of investigations like TSH and free T4. You will be doing FSH, you will be doing prolactin, you will be doing total testosterone if the patient is showing hyperandrogenic features, and you will be doing progesterone challenge testing. So a lot of tests you can perform, and you can find out what is the primary problem. There could be early PCOS also, which can manifest as primary amenorrhea. Remember, PCOS can manifest as primary amenorrhea or secondary amenorrhea, or even a oligomenorrhea, or even a menorrhagia, which I have discussed in detail in the next chapter. So now, if all these investigations are normal, then finally you can reassure the patient that it is just a constitutional delay. So, but you have to rule out all the other conditions. Clear? So, suppose if the uterus is not there, which means the Mullerian structures is not there. So, in this condition, it's better to see the karyotype, because there could be a testis producing anti-Mullerian hormone, and because they are males, they are not able to menstruate, and because the testis is producing anti-Mullerian hormone, you don't see the uterus. Possible. So see the karyotype, see whether it's a XX karyotype or a XY karyotype. If it's a XX karyotype, obviously it's not a DSD. I told you this diagnosis doesn't fit into DSD in the first place. Already we have discussed in the previous chapter. This is nothing but Mullerian agenesis, or otherwise simply referred to as a uterovaginal agenesis, or you can even call it as a Mayer-Rokitansky-Kuster-Rosser syndrome, MRKH. And if it's a XY karyotype, a lot of possibilities are there. Now you are actually encountering a DSD where it's actually a male, but Mullerian structures are not there and they are grown as females, and that's why you are confusing it as a female with a primary amenorrhea. So this condition usually goes towards a complete androgen insensitivity syndrome. And it's a spectrum which we have discussed already. So in exams, it goes towards a complete androgen insensitivity syndrome. Please do understand, in Mayer-Rokitansky-Kuster-Rosser syndrome, your pubic and axillary hair is supposed to be normal, which we have discussed in great depth in the last chapter itself. Whereas in complete androgen insensitivity syndrome, your pubic and axillary hair will not be present and it will be defective because of the androgen receptor resistance. Suppose if you do not have this secondary sexual characters, which means you don't have this breast development, which means you are dealing with low estrogenic states, which means the ovaries are not producing estrogen. The ovaries not producing estrogen may be either due to your pituitary not having the sufficient gonadotropin stimulate the ovary to produce estrogens, or the ovaries by default are having some disease so that they are not producing estrogens by themselves. So what are the reasons for the same? So now we have to see the FSH, and based on the FSH you can clearly find out, because this low estrogenic state means either it could be a hypogonadotropic hypogonadism, where your FSH levels are low or normal. Remember, even a normal FSH value in the presence of low estrogenic state is definitely abnormal. That is how endocrine principles work. Or it could be a hypergonadotropic hypogonadism. Hypergonadotropic hypogonadism, which means the gonadotropin levels are high, which indicates a very high FSH, usually in the menopausal range, but because of that you are not having like menstrual cycles. Clear? Because the ovaries are dysfunctional here. So this usually locates your problem to the pituitary and hypothalamic axis. So this locates your problem in the hypothalamic and pituitary axis. This usually locates your problem in the ovary. It's an ovarian issue. So pituitary and hypothalamic issues can be further delineated into either it could be a hypothalamic problem or it could be a pituitary problem. Remember, hypothalamic problems can be multiple. So probably it could be a hypothalamic amenorrhea, which is quite rare. Usually they cause secondary amenorrhea only, but still it is possible to have a hypothalamic amenorrhea. Or it could be an isolated GnRH deficiency. Isolated GnRH deficiency usually happens in patients with Kallmann syndrome, where the patients generally tend to have an isolated GnRH deficiency causes hypogonadotropic hypogonadism along with anosmia due to absent olfactory bulbs. We have discussed it already in the pituitary basics. Or many other conditions which I already discussed can produce this hypothalamic amenorrhea, primary amenorrhea. And pituitary causes, lots are there. In general, we think about pituitary radiotherapy, insult to the pituitary, or a pituitary tumors, or probably could be a hyperprolactinemia due to a pituitary adenoma or due to some other reason. So a lot of conditions are there. So these are some of the examples of pituitary conditions causing hypogonadism, hypogonadotropic hypogonadism. Whenever the FSH is high, we know it's a hypergonadotropic hypogonadism and the problem is likely to be in the ovary. So in this condition, it could be a gonadal dysgenesis where the ovaries are lost. This gonadal dysgenesis could be due to either XX or XY probably. And again, the physiologists and pathophysiologists behind this XX and XY gonadal dysgenesis, we have already discussed in the previous video itself. Or it could be Turner syndrome. Turner syndrome, you can classify either under premature ovarian failure, or you can classify Turner syndrome under gonadal dysgenesis also. It means there are two pathophysiologies that are overlapping with regards to Turner syndrome. So Turner syndrome is one of the important causes here. So remember this gonadal dysgenesis, again it could be XX or XY. XY means they are actually men with who will be having this persistent Mullerian structures because of testicular dysgenesis, and there is no AMH to produce this, to suppress these Mullerian structures. And at the same time, since they cannot produce testosterone, they will be born as females and they will be reared as females. This XY gonadal dysgenesis is what we refer to as Swyer syndrome, and we have seen a whole lot of causes that can produce this Swyer syndrome. Clear? And the Turner syndrome patients, again, we are going to discuss in detail, but Turner syndrome have a lot of variants. You have a classic Turner syndrome or a lot of mosaic Turner syndrome. So remember, again, the height generally varies. For example, usually in gonadal dysgenesis patients, the height generally tends to be normal, whereas in patients with classic Turner syndrome, they generally tend to be having a short stature. This is due to problems in the SHOX gene, which we are going to discuss in detail in the subsequent section. So, or in mosaic Turner, the height is generally variable. So, you cannot really tell where the height is normal or reduced. Some patients may have reduced height, some patients may have normal height, some patients have a subnormal height. It's all variable because mosaic is something different, which I'll be discussing in the subsequent minutes. And pituitary, you know that patient may have a panhypopituitarism or a gonadotropin deficiency alone. If they have an isolated gonadotropin deficiency like Kallmann syndrome, their height will be normal. They won't have any problem in the height because here the growth hormone production is normal. In patients who are having panhypopituitarism, generally your height tends to be low, obviously because of the loss of this growth hormone. So in a nutshell, whenever the patient is presenting with primary amenorrhea, the first thing you have to see whether is the secondary sexual characters present or not, which tells you the presence or absence of estrogen. If the patient is having estrogen, they will have secondary sexual characters. They'll have breast development. Next step is to see the ultrasound to see whether the uterus is present or not. If the uterus is present, rule out outflow tract obstruction. If the uterus is absent, you're going to rule out whether it's a DSD or not a DSD. In this case, whether it's an MRKH or a androgen insensitivity syndrome. So if the breast is not seen, which means if the secondary sexual characters are absent, the next step is to find out whether the cause of this low estrogen is due to pituitary hypothalamic conditions where you'll have a low or a normal FSH, or if it's an ovarian condition where you're going to have a high FSH. And height is variable in the scenarios depending on the condition you're going to see. And you have to always be very sure about one fact, that the most common cause of primary amenorrhea in the world is Turner's syndrome. And that is also one reason why we have to discuss this Turner syndrome in detail, in depth, and that's what we're going to do now. So remember, Turner syndrome is one condition where you can discuss this in cardiology, you can discuss in endocrinology, you can discuss this in pediatrics, you can discuss this in gynecology as well, because this is going to produce a constellation of findings and constellation of symptoms and signs that necessitates its discussion in every single medical field. So that's why Turner syndrome is really, really important. But what are the basics of Turner syndrome? Remember, Turner syndrome is nothing but it happens in females. For sure, you have to be very, very clear that these are actually females. And the females, you know, they are going to have 2 X chromosomes. And out of this, 1 X chromosome in Turner syndrome is completely normal. There is no doubt about that. And this is the criteria for, in fact, diagnosing Turner syndrome. And another X chromosome in this female is going for a toss, which means it might be lost either completely or it might be lost at least partially. Clear? Which means 1 X chromosome is normal and the other X chromosome is abnormal. This is Turner syndrome. That's it. Which means they are females without a doubt, where the Endocrine Society clearly tells you cannot diagnose Turner syndrome in a male due to any reason. At the same time, patients who are having DSDs or disorders of sexual differentiation cannot be diagnosed as Turner syndrome. Clear? Which means they are genetically and phenotypically females. That's the most important point. Clear? And you will be asking the fact, because Turner syndrome, for example, you'll be seeing a classic Turner syndrome that is 45XO. That's what they are given, which means they have only 45 chromosomes and they have only 1 X chromosome and another X chromosome is completely lost. This is what we refer to as a classic Turner syndrome, which I'll tell you in some time. But the most interesting thing that usually comes under discussion is whether this single X chromosome that is seen in classic Turners is coming from father or a mother, which means it's paternal maternal origin. Studies say that this single X chromosome is of maternal origin in 70% of the cases and is of paternal origin in 30% of the cases. And why they wanted to know this is the fact, just not for curiosity, they wanted to know this to correlate with the diseases, because there are certain things which correlate well whether this X chromosome is obtained from paternal side or maternal side. When it's obtained from maternal side, they go for some unique clinical features. When they are obtained from maternal side, they go for some unique clinical features. That's why this is important. They are obtained from maternal side in 70% of the cases and from paternal side in almost 30% of the cases. And before going into any detail of Turner syndrome, it's very, very important to understand the baseline genetics, which is the key. So remember, this is the normal female karyotype. In the normal female karyotype, you are having this XX chromosomes, 2X is there and there is no Y. Normal female karyotype. And this is a normal male karyotype where you can clearly see the patient is having a XY chromosome and not a XX karyotype. And you can also note one striking point, that this X is considerably shorter and it is having very less number of genes compared to the other X chromosome in the female, right? So which means it produces a genetic inequality, isn't it? Which means the females are actually having higher number of genes compared to the males, and this should never happen. According to evolutionary principle, it creates a genomic instability and that species will not survive over time. So to avoid this genomic and genetic instability due to females apparently having excess amount of chromosomes, excess amount of genes, this one of the X chromosome should be inactivated. Clear? So this process is what we refer to as lionization. Please do understand the fact that all the genes in that particular X chromosome will not be inactivated. This is very important, because otherwise if the entire X chromosome is inactivated, that again will create a genetic inequality because males are having some additional extra genes. So to compensate, to equalize this number of genes, certain genes in that X chromosome will be inactivated. Clear? This process is what we refer to as lionization. This process is what we refer to as lionization principle. So this is the X and X. Let us assume this is the shorter P arm and the longer Q arm. So during the process of lionization, this lionization process happens during the time of gastrulation. So during gastrulation, there will be already a pool of cells that are already formed, and each and every individual cell can differentiate into, these are multipotent cells and they can differentiate into different group of cells, different tissues, and they can produce different organs. And at the stage of gastrulation, when there are a pool of cells and these cells will have a random inactivation of one X chromosome, particular genes, not the entire X chromosome, some genes in that X chromosome will be randomly inactivated. Remember, this process is random. It's not the same X chromosome is inactivated in all the cells. And whenever that particular cell differentiates into different tissues and that X chromosome which is inactivated in that particular cell will be the same, like same X chromosome that is inactivated in the other group of cells that is going to differentiate. But at the gastrulation stage, the inactivation of a particular X chromosome is random. Clear? That's very, very clear. So now, what is the reason for this inactivation? We know the reason for this inactivation, but what are the molecular mechanisms behind this inactivation? We have a particular protein called ZIST, which is coming from ZIST gene. This is called the X inactivating site. So this X inactivating site or a ZIST protein is going to inactivate certain genes in the another X chromosome, which are destined to go for lionization and inactivation. So this is going to inactivate some specific, not random, specific set of genes in the remaining X chromosome, which is supposed to be lionized. And this process is random during the gastrulation stage, which has to be very clear. But there is always a question that is asked by the student, any student. So normally, sir, you told that in a Turner syndrome, one X chromosome is lost. In a classical Turner syndrome, let us assume one X chromosome is lost, only one X chromosome is there. And in a female who's having a normal karyotype itself, one X chromosome is inactivated already through this ZIST process. Then why you should develop Turner syndrome? So I think you can get this. So if already one chromosome is inactivated in a normal female with a normal karyotype, so even loss of one X chromosome in Turner syndrome should not result in a syndromic appearance. But why you should develop in a Turner syndrome? So the idea is very simple. That's why it's stressed on the fact that this lionization is a process where there will be inactivation of specific and certain genes in another X chromosome, not the entire X chromosome. Which means there will be certain genes which will be escaping this lionization or inactivation in that particular X chromosome, and these genes are what we refer to as pseudo-autosomal region 1 and pseudo-autosomal region 2. It is present on both the P arm as well as the Q arm, which means the pseudo-autosomal region that is present on the end of the chromosome, that is a lionized chromosome, will be still active and it is not susceptible to inactivation by this ZIST gene and the ZIST protein. Clear? So this loss of this pseudo-autosomal regions is the reason for developing Turner syndrome, which means these pseudo-autosomal regions are still active in a female with a normal karyotype. But in Turner syndrome, when you lose this, one of the X chromosomes, the loss of this pseudo-autosomal regions, which are supposed to be active in a female with a normal karyotype, is the reason why you develop this syndromic appearance. So which means there should be some genes in the pseudo-autosomal region which is responsible for whose loss is responsible for the manifestation of the Turner syndrome. So what are those genes? So in the pseudo-autosomal region 1, that is present on the shorter arm, that is the P arm of the X chromosome, is a submetacentric where there is unequal lengths of P and Q arm. That's why we call it as submetacentric chromosome. And in the P arm, in the shorter arm, there is something called a pseudo-autosomal region type 1, which is still active. And loss of this is the reason for developing this syndromic appearance. And this PAR1 is very, very important and gives rise to the most of the features of Turner syndrome. So what are the genes that are lost in Turner syndrome in this pseudo-autosomal region type 1 that is going to give rise to the syndromic features? One, the most important is the SHOX gene, which I have described already. This SHOX gene is important for this formation of this growth plate and the skeleton. And loss of this SHOX gene is the reason for development of this short stature and conditions like Madelung deformity, which I have an X-ray for it, which I'll show you in some time. Madelung deformity, which happens in the radius. And second gene that is inactivated is this BMP15, which is very, very important for ovarian development. Ovarian development. So because of the same reason, because of this loss of BMP15, these patients will go for ovarian failure and streak gonads, which is one of the very important features of Turner syndrome, right? And next, you have this XP11.4 area whose function is unknown. We don't know what is the exact function of this XP11.4 area. And loss of this area in the PR1 is supposed to be thought to be the reason for development of this lymphedema in Turner syndrome. Lymphedema means more fluid in the body. More fluid in the body means the kidneys will be affected because of that. That is also the reason why Turner syndrome patients are having renal defects as well. Not all. Some of the patients with Turner syndrome will have renal defects. Remember, almost all the patients, 100% of the Turner syndrome patients, unless until they are mosaic Turners, they are going to have this SHOX gene involvement and short stature. And next, you know this PAR2 is also very important. This is pseudoautosomal region type 2, which is present on the other end of the X chromosome on the Q side, on the longer arm. So loss of this gene, some of the genes in the PAR2 is going to result in some of the syndromic features that are related to Turner syndrome. And the very important gene is FMR1 and 2. This is related to Fragile X syndrome. This is a Fragile X related gene. That's why it's called FMR1 and 2. And this is related to ovarian function again. Ovarian development and function. And loss of this gene is probably thought to be the reason for this ovarian failure. Ovarian failure. And the second gene that is very important is the TIMP1 and 3 gene. This loss, the important function of this TIMP1 and 3 is cardiac development. Some element of cardiac development is associated with TIMP1 and 3, and probably loss of this TIMP1 and 3 is supposed to be the reason for development of this cardiac defects in certain individuals, especially this left-sided cardiac defects, which are very common, aortopathies, very, very common in Turner syndrome. So these are the genetic basis of Turner syndrome in the first place. Then there are some types of Turner syndrome in the karyotype. So here what you are seeing is the 45XO, which means there is no X chromosome at all, which means one X chromosome is completely lost. And this is what we refer to as a classic Turner syndrome. This is a classic Turner, where one X chromosome will be completely lost. Only one X chromosome will be there. That is normal, fairly normal. And this is the karyotype which you can get in the exam, where you can clearly see there is only one X chromosome. There is loss of another X chromosome. This is a classic Turner. Fine. So this type of Turner is what we refer to as isochromosome XQ. So what do you mean by isochromosome XQ? I clearly told in Turner syndrome, the problem is one X chromosome will be completely normal. If another X chromosome is having some problem, that is also a Turner syndrome only. So what is the problem in this isochromosome XQ? Here you can see the P arm is completely deleted. P is deleted. And because the P is deleted, here the Q is actually duplicated. So there is no P arm here, and both the arms are made of Q only. The Q is duplicated to produce the complete X chromosome, which means here the main problem is the PR type, PR1, that pseudoautosomal region 1 that is associated with the P arm is lost. You don't have this pseudoautosomal region type 1. So which means loss of this PR type 1 means you will still result in classic Turner syndrome. Classic Turner syndrome. But this isochromosome XQ will make the patient susceptible for one important extra manifestation called they are more prone for autoimmune thyroiditis. Which means if they ask you what is the additional thing that you will see in isochromosome XQ related Turners, you will have more incidence of autoimmune thyroiditis in these patients with isochromosome XQ related Turner syndrome. You can see very clearly here, this is the abnormal chromosome, here is the Q arm, this is also the Q arm. So you can see this is the P and Q. P is little bit shorter, but here both are of equal length, which means both are made of Q. And this is what we refer to as isochromosome XQ, a type of Turner syndrome. And again, problems are due to loss of PR1 on the P arm side. So that happens in this type of Turner syndrome. And the third one is P deletions. P deletions. You can see a lot of chunk of P is not there, deleted, and only a small amount of P is there. This is another type, XP deletion. So what you can see is here you have a small P, but remaining P is not there, and Q is okay. So again it is due to XP deletion, and once P is deleted, again you will be losing this PR1, that is pseudoautosomal region type 1, and that is the reason for same manifestations of Turner syndrome, and they will have all the classic manifestations of Turner syndrome because this PR1 is more important compared to the PR2. in the manifesting the Turner syndrome. And the fourth type, karyotype of Turner syndrome, you will be encountering a ring chromosome. What do you mean by ring chromosome? You have this you have this P and Q arm of the chromosome. So what happens is the ends of the P and Q arm will be deleted, will be removed, and the remaining P and Q segments will fuse together to form a ring. So this is what we refer to as a ring chromosome. This is the P, this is Q, but please do understand that the ends of the P and Q will be lost, deleted here, and they will be joined together to produce this ring chromosome, which means here again you are losing this par 1 as well as par 2, the pseudoautosomal regions 1 as well as pseudoautosomal regions 2. Both these things are lost, so will result in almost all the classic features of Turner syndrome, but with one important problem you will be facing. I'll tell you what. So you can see in the karyotype, the another X chromosome, you can see clearly it forms the ring. This is what we refer to as a ring chromosome. And you will see all the classic features of Turner syndrome. Plus, at the same time, you will be seeing mental retardation and syndactyly. So why suddenly this should produce mental retardation and syndactyly? Curiosity. Here it tells you the fact that there is X inactivating site, that cyst, that also comes from the X chromosome. So in patients who are forming this ring chromosome, there is cyst dysfunction. That's the idea. So listen carefully. If you have cyst dysfunction, normally what cyst should do? Cyst normally should inactivate certain regions in the lineaged X chromosome, right? So because of the cyst dysfunction, there will be inadequate inactivation of X chromosome that is supposed to be lineaged. So there is inadequate inactivation of this X chromosome that is supposed to be lineaged, which means there will be extra genes that are active in these patients. Along with loss of this PR type 1 and PR2 in the ends of the chromosome, X chromosome, there will be inactivation of cyst, which means there will be inadequate inactivation of these genes that are supposed to be inactivated by this cyst, and there will be extra genes that will be active in these patients, and this is thought to be the reason for MR and syndactyly in these individuals. So in a ring chromosome formation, there will be loss of PR1 and PR2. Along with it, there will be cyst dysfunction. Because of that, you will result in mental retardation and syndactyly. It's quite rare. In general, if you take a Turner syndrome, they'll be having a normal intelligence. That's very important point. In exams, whenever they ask you about Turner syndrome, you have to always answer they have normal intelligence. But exception is the ring chromosome type of Turner syndrome where they can have a mental retardation. And finally, this is what we refer to as a marker chromosome. So when you look at it as a marker chromosome, when you don't know the origin of this remaining chromosome, you have a X chromosome which can be clearly defined. It's a normal X chromosome. That is the definition of Turner. And the remaining X chromosome, you don't know whether it's X or it could be even Y. You don't know what is this and where it is coming from. The common hypothesis is the fact that there will be deletions and alterations of the remaining X chromosome due to some genetic aberrations in so much way that there will be only few segments in the P arm and the Q arm left which will be fused together to produce this marker chromosome. Clear? So this is what we refer to as marker chromosome, and the most important thing is the fact that this marker chromosome can even have a Y material with it. So I'll tell you what is the problem with this Y material. So first I'll show you the karyotype image of this marker chromosome. You see clearly this X chromosome here, but you really don't know what is this chromosome. This chromosome is the marker chromosome. We don't know the genetic material of this chromosome, where it is coming from. We cannot clearly band it through our studies, karyotyping studies. So obviously, whenever you see a marker chromosome, in exam, if they ask you, the next step is FISH. You have to find out through FISH whether FISH will tell you whether this chromosome is containing this Y material or not. Suppose if this marker chromosome is containing Y material, there is a high risk of development of gonadoblastoma, and this gonads has to be removed. So you have to find out these gonads and you have to remove them. So that is the importance of doing FISH in this scenario. But overall, I'll tell you some important points. Around 10% of Turner syndrome patients, this is a very important point, 10% of Turner syndrome patients may have some Y material in them due to genetic aberrations, especially if you are encountering a marker chromosome. Clear? So they may have Y material with them, and whenever they have Y material, there is extremely high risk of developing gonadoblastoma, increased risk of gonadoblastoma, and this presence of Y material may also result in virilization. during puberty. So, and that is also one of the reason why in this patients, you have to take these patients for gonadectomy, and that is the importance of fish in a Turner syndrome. If they ask you, the most important reason for doing a fish is to find out this Y material. If there is a Y material, you have to remove the gonads. There is no other option. 10% of Turner syndrome patients will have this Y material. So, point number 1. So, and point number 2 that you have to note is the fact that there is something called a mosaic Turner. What do you mean by a mosaic Turner? So, what is called a mosaic basically? So, whenever you have different mosaic appearance, like that's what we call, isn't it? So, you see tiles and mosaics. So, how does this mosaics look? Certain mosaics will have a different color, and certain mosaics will have a different color, and certain will be having a different color. So, this is what we call as a mosaic. So, similarly, so each and every individual cell is having different karyotype. For example, this cell is having a Turner's karyotype, and this cell is having a different karyotype. For example, they are having 46XX. So obviously this is what we call as a mosaic, which means in a particular individual, different group of cells are having different karyotypes. So common mosaic patterns means the patient one group of cells, which means a certain group of cells may have a Turner karyotype or a Turner abnormality. Turner karyotype. So which means this Turner karyotype can be anything. This Turner karyotype can be anything. It could be classic 45XO, or it could be a ring chromosome or isochromosome XQ. Even the 45XO is very common. So let us assume an example of a 45XO, that is 45X. And some other group of cells, certain group of cells will be having a different karyotype. For example, a 46XX, which is a normal karyotype, 46XX, or probably a 47XXX. So remember the fact that other cells are having normal karyotype means these cells will behave normally. So they are trying to compensate for the Turner defect in certain cells. So the more amount of X chromosomes you have, the compensation will be more. So which means this patients with 47XXX will have more compensation to this Turner karyotype, and they will neutralize the Turner effect cells in comparison to the patients who are having purely only Turner's karyotype, which means mosaic Turner patients generally tend to have lesser clinical manifestations. Lesser clinical manifestations, and the clinical manifestations are dose dependent. So what is the dose dependent means here? You have studied about drugs where the side effects are dose dependent, but here the dose dependent means what is the dose of the Turner's karyotype, which means in the entire body how many cells are having this 45X, and how much Turner's karyotype is seen. If the more the Turner's karyotype are there, more will be the clinical manifestation, which means more is the abnormality. Lesser the Turner karyotype, more is the compensation with other cells producing more X, having more X, you will be having lesser clinical manifestations, which means depending on that, patient may not even have a short stature and they may have even a normal height as well, but that's quite rare. So this is what we call as a mosaic phenomenon, and this is quite common in Turner's syndrome patients. So these two things you have to understand very clearly. So these are the genetics of Turner syndrome, which has to be understood in a detailed way. So now we are moving on to the clinical features of Turner syndrome.